There is no conflict of interest to declare. Arthroscopic procedure for an isolated coronary bucket and meniscal tear at Thammasat University Hospital, Thailand. Clinical diagnosis is made following a detailed history and clinical examination. Usually, the patient has about 5 to 10 degrees of inflection deformity as attempt at full extension is usually painful. X-ray is done to rule out osteochondral lesions, and magnetic resonance imaging is also done to confirm the diagnosis. This is usually seen as a double PCL sign. Position supine with the affected limb hanging at the edge of the operating table. Segment of the medial meniscus is usually seen in the intercondylar notch, thus confirming the diagnosis of isolated bucket handle meniscal tear. At reducing the displaced torn meniscus, this is usually difficult because the medial compartment is usually tight. Thus, we do a subcutaneous release of the posterior fibers of the medial collateral ligament using picrostin. The effect of this maneuver on the visualization of the medial compartment is instantly obvious. The bed is refreshened using a 4.5 mm shaver blade. The torn surface of the meniscus is equally refreshing. Biologic healing is stimulated by fenestration using a 1.8 mm Kirschner wire going to a depth of about 2 mm on the bed in several places. The displaced meniscus is done easily reduced with the use of a probe. Repair is commenced on the medial side. Vertical sutures are placed from the upper part of the meniscus into the substance, and that is opposed to the bed with a tension applied by the assistant collecting the sutures on the medial side of the knee. Horizontal suture is run over the vertical sutures, thereby creating a Mason-Allen effect that will enhance surface contact rather than suture point contact. The part and all inside technique is done using both the straight and the curved fast fix by Smith and Nephew. Suturing is done at both the upper part as well as the lower part of the meniscus, thereby also ensuring surface contact rather than suture point contact. Outside the skin medially, the sutures are collected. A 1 to 1.5 cm vertical incision is made between the two rows of sutures. The incision is deepened down to the capsule using artery forceps. This is gently done to avoid damage to the branches of the saphenous nerve. The sutures are retrieved one after the other through this wound. A tug is made on one arm of the suture to identify the other arm, and as such, knots are made directly on the capsule, one after the other. Suture knotted under direct vision as shown. The wound is closed and the patient leaves the suit in a brace locked in full extension. Exercise commenced as 2 weeks postoperatively. Patient is followed up at 2 weeks, 6 weeks, 3 months, 6 months, 1 year, and 2 years. At 6 weeks, we can see that there is no pain at full extension, and patient can flex the knee very well. There is no area of numbness to suggest nerve injury. It was performed by Associate Prof. Dr. Banchachan Chujit and reported by Ibrahim Abolaji Alabi.